Fantastic. So today we will be talking about SMA gene therapy, spinal muscular atrophy, looking at the data, implications, and global perspectives. And we're really grateful that Dr. Christian is here today to speak about this topic. This is something that has been highly requested from the community to hear more. And we have some medical trainees, clinicians on the call today. I'm not seeing your slides quite yet, but I'll continue to wait. I know you.
Do you mind? I can share my screen. Can you just unshare, and then I can share my screen. And I can share my presentation. Yeah, great.
Absolutely. There we go.
I would do it. Perfect. And then.
Great. And as Dr. Christian's doing this, I can go ahead and introduce Dr. Christian. As I mentioned, we're really grateful that he's here today. Dr. Christian completed his adult neurology training at Laval University. He then pursued his training in pediatric neurology at McGill University. He performed his clinical fellowship in pediatric neuromuscular disorders at the Hospital for Sick Children in Toronto. He came back as a staff member in the pediatric neurology team of Quebec City with his subspecialty in neuromuscular disorders and neurogenetics. He is currently involved in the field of neuromuscular disorders and genetics, and he is working in new phenotypic presentations of neurogenetic diseases. We're really grateful to have you today to be able to share your findings and information on gene therapy for SMA. Go ahead, Dr. Christian.
Thank you very much. Thank you for your patience. I'm really sorry. I had a last-minute patient, and it was pretty long, so it was a complicated case, and it was a patient with spinal muscular atrophy. So this is right on the team. So let's talk a little bit about gene therapy, particularly with spinal muscular atrophy. These are the disclosure of this presentation, my specific disclosures and disclosure of the people involved. So I've been involved with as a clinician for as a clinical advisor for a couple of companies, Roche, Biogen, Novartis, Genzyme. So here are the objective of this presentation. So it's a pretty large panel. So I want everyone to be able to get some of the key points about SMA. So we talk about SMA, the diagnosis. How can we do? Why the diagnosis can be still delayed? We will explain a little bit how the gene therapy works, and we will explore potential implication. And we'll discuss a little bit about some of the results from the study. And we give you some updates, recent updates, particularly in Canada and Quebec, about gene therapy in patients with SMA. Oops, sorry. So same thing, we'll go over the presentation. First part will be about SMA. Second part with early diagnosis and screening. Third part, the gene therapy. And then I will answer to your question. And do not hesitate to ask me a specific question. I like to be challenged. There is a pretest. So at the end of the presentation, you can complete the test and you can do the test while I'm talking. SMA. So spinal muscular atrophy is probably one of the most common neuromuscular autosomal recessive. So that means that each parent were carrier of an abnormality, and the combination of the abnormality brings the disease. It's a very severe and lethal disease. Up to recently, spinal muscular atrophy was the most common neuromuscular disorders leading to death. The reason of 5q spinal muscular atrophy is a deletion of exon 7 in the gene called SMN1. SMN is for survival motor neuron. So that was a pretty good name because we realized that the motor neuron, the neurons that are in the spine, in the anterior horn, that gives rise the nerves will stimulate the muscle. So this specific nerve will degenerate. The thing is that we know that the phenotype of the patient with SMA will be different despite the same genetic implication, and the difference is triggered by the number of copy of SMN2. This is second gene, and I will explain why. Yeah. So you will understand that mainly the lower motor neuron will be affected. If it's affected, you will develop slowly progressive uh, sorry, implication in the sense that we develop weakness, atrophy, you will lose muscle bulk, you will lose reflexes, but also you have to understand that you will develop slowly respiratory distress, and you will develop bulbar dysfunction. This is why that will lead you to a certain point of death. What's happening with the normal individual? So normal individual will have at least one copy functional of SMN1 and will produce more than 90% of the SMN protein. We have a second gene. So on the other side of the same chromosome, chromosome 5, we have SMN2, another centromeric gene. The only difference is on the exon 7, there is a splicing silencer. That means that sometimes the gene, there is a skipping of the exon 7. So the gene is not completely transcribed, and they will produce a protein which is not functional. But 10% of the time, there is a complete transcription of the gene, and then you will have a full length SMN protein. What's happening with patients with SMA? So there is no copy of SMN1, so they are dependent of SMN2. Could have up to 6 copies of SMN2. Patients with type 1 SMA, they have usually less than 3 copies of SMN2. That means they have a low level of SMN protein. That explains why the lower motor neuron will not survive. So the main the main area of treatment was to increase the SMN level of protein. So these are the formal presentation of patients with SMA. They were divided in 4 up to 5 types, depending on the severity. The type 1 is the most common, usually arising around the age of 3 months, with lifespan less than 2 years. Most of the patients, more than 84% of the patients will die before the age of 2. Usually they have less than 2 SMN2 copies. Type 2 and type 3, they were less aggressive. They are subtype because sometimes type 2 could present a little bit earlier than usual. And the type 2, they were the patient called the sitter, but the non-walker. Type 3, they were the patient that will be able to walk at some point, but they were patient type 3A that they were able to walk just for a couple of weeks or months, and then they will go back to the wheelchair after that. But they will have normal lifespan, but with severe disability. The thing is, with all the treatment that we talk about, the phenotypes are changing with the treatment. So this classification will not be useful anymore. And I will present you a couple of videos. I will call that the historical case, in a sense that in the near future, these are the kind of patients we don't want to see anymore. So here is a patient with with hypotonia, severe hypotonia, no symptoms at birth, but at the 2 months, you see the patient difficulty to lift the lead. So there is significant head lag. Second video at the same time, you can see that the physician tried to stimulate the baby, is intrigued by these toys and try to lift up, but not moving the arms. You can notice there is no movement of the leg, and you can notice the breathing. There is a paradoxical breathing, more breathing with the abdomen, breathing pretty fast. Third videos is to show you the hypotonia in the lower leg. So the patient is not able to keep the leg at least for a couple of seconds together, which is a really good sign of severe hypotonia. So when you have a baby not moving the leg, very interactive, but not moving the arm so much, no reflexes. First clue you have to look for the tongue and tongue fasciculation. This is more movement on the side of the tongue, and the fasciculation means denervation. So there is a degeneration of the nerves, and then the muscle, the fiber will trigger movement, but uncontrolled movement. So this is the first clue, and you need to refer the patient as soon as possible to a pediatric neurologist. And I will explain to you why the importance of early diagnosis and screening in SMA. Now we have the tool in a sense that we don't need the EMG anymore to diagnose patient with type 1 SMA. We can go directly to genetic testing. There's two ways to do the genetic testing. There is the way with expansion with PCR or MRPA. No matter what, you're looking for 0 copy of SMN1. If this is the case, you have a confirmed case. You have to consider that sometimes you find 1 copy of SMN1, but the 1 deletion, but you cannot find the second deletion. 5% of 5q SMA, you could have a point mutation. So this is really important to consider that, particularly if you have a patient with typical presentation. And then you have to assess the number of copies of SMN2. This is really important for the therapies to see if there is indication to start gene therapies for your patients, depending on the number of SMN2 copies. And that will help you relatively to predict the evolution of the patient. If the patient is atypical, you have to consider to complete your evaluation with the EMG, consider other genetic panel for the non-5q SMA. And I think this is one of the most important key points to remember from this presentation is the diagnostic delay. This is a really good graph showing you that type 1, on average, 3 months before we are able to get the right diagnosis. Type 2, 14 months. This is pretty important to keep that in mind according to what I'm gonna talk to you in a few seconds. And type 3, this is pretty long. And type 3, it's almost 2-3 years before someone realizes that there is something abnormal with the kidney. And most of the time, the people, they consider that the patient has a myopathy until you are doing an EMG, and then the EMG is showing you nerve degeneration. SMA severity and phenotypes. So you remember that the severity and the phenotypes depending on the level of the number of SMN2 copies. But we know that depending on the number of SMN2 copies, even if you have 3 or 4 copies, you have still a risk of developing type 1, so the more severe SMA presentation. Type 3, 3 SMN2 copies is the most difficult one to predict. Is really on a clinical base. I mean, you could have 50% will have a type 2 presentation, but still 70%, close to 20% could have a type 1 presentation. They could be in between, could be severe, so severe type 2, and you can still have 30% could have type 3. But most of the time, a severe type 3. That means they won't walk for a very long time. SMA screening. So carrier screening is really important because if you know if the parent, they are carrier, you can predict already what will happen to the patient. And you can be involved in the treatment of the patient very early on. Pre-implantation or prenatal testing is available in Canada in tertiary center if you have a positive family story. So in Quebec City, particularly in the region of Saguenay-Lac-Saint-Jean, the level of carrier is pretty high. So if you have a family history, we can test the parents to see the carrier status. It's pretty easy with the sampling of the chorionic villus or by amniocentesis. went to establish a newborn screening program. So what are the main criteria of screening? So the disease is life-threatening and treatable. Now this is the case for SMA. Second, early diagnosis improves the outcome. Definitely, and I will show you that. Newborn screening is feasible. And then we know that it's feasible because a couple of countries already, as some of other provinces started recently to do the newborn screening. And newborn screening improves outcome. This is what we're expecting. So what are the evidence of developing newborn screening and treating patients very early on? So the first medication that arrived on the market was nusinersen. And we have a couple of studies of nusinersen. I'm really sorry. This is a pretty busy slides, but what we need to focus on is really the two curves on the upper part of the graph and the other curves on the lower graph. The scale is from 0 to 26. So this is the high knee. It's a motor developmental milestone scale. And the two curve on the upper side, this is nurture study. The nurture study was treating the patient pre-symptomatic. So they were aware that they would develop the disease or very early on, before the age of 2 months, they started the treatment. And the other curve, they were the handier the shine. So handier shine, they were the type 2 and the type 1 SMA diagnosed, but with the evolution of the disease for a couple of months or years sometimes. So you can see the dramatic change and the evolution with patients close to normal developmental score when they were treating pre-symptomatic comparing to the treatment comparing to the other patient treated later. So the still improves, but slowly are pretty stable with the medication, but they're not dying anymore, which is still a great improvement for these patients. But they are left with severe disability. So data support gene therapy studies. And the sooner is better. So if I change a little bit the graphic, I compare Indir, which was the type 1 SMA patient treated later, comparing to Nurture, type 1 or type 2 SMA patient, but treating pre-symptomatic. You can see that first, 87% of patients, they are walking. They're not supposed to walk, so they are walking with the treatment. Close to 80% unassisted walking. So you defy the natural history of the disease. And the most important, 100% no permanent ventilation. So the conclusion is treating the sooner is better. What about the experience of other countries with newborn screening and the utility? So the German experience was very interesting. They screened close to 100,000 patients. And this is close to the incidence of SMA. Usually it's between 1 in 10 out of 100,000 patients for new birth. So they diagnosed 22 patients, 10 with only 2 SMN2 copies, 4 3 SMN2 copies, 8 with more than 4 SMN2 copies. The one with the 4 SMN2 copies, it's difficult because probably you have to be a little bit more conservative because they will have probably a more slowly progressive disease. Even they could present later on. So you have to reassess the patient frequently. But the one with only 2 or 3 SMN2 copies, immediate treatment with nusinersen. The patient, they evolve pretty well. So the newborn screening resulting in pre-symptomatic treatment and improves significantly the outcomes of the patients and the children with SMA. So recently, May 2019, the group, the European group, they presented recommendation with the newborn screening, and they really pushed to develop newborn screening, particularly in Europe, but also to develop a worldwide program. At the end of this meeting, they present recommendation, and basically recommendation is to start newborn screening as soon as possible, and to be sure you have a lab, you have access to genetic testing, and you have a reliable laboratory to precise the number of SMN2 copies. What about newborn screening in US and Canada? So particularly in Canada, in Ontario, they started the program more than a year now. In Alberta, I think they are close to start. But unfortunately for the other province, we're far from being able to start compared to other states in the United States, which is pretty a shame. And I will explain to you why in a couple of seconds. In Europe, in Belgium, Italy, Germany, Slovenia now, Middle East, there's nothing yet. Africa, nothing. South America, they're pretty late. But in Asia, Japan, they started recently, and Taiwan, China also, and Australia, different provinces, they started newborn screening and even carrier screening. Gene therapy in SMA, how it works and potential implications. So that's the core of the presentation. So what were the different approach? Before nusinersen and Zolgensma, the first approach was to try to increase the production of SMN. We tried valproate acid, which was an antipyretic medication, or Riluzole, which was a medication used for another degenerative disorders, for amyotrophic lateral sclerosis, but without significant improvements. Later, we tried to increase contractibility using salbutamol or levocarnitine without significant improvements. Then arrived nusinersen and other medication in the pipeline to increase SMN2 transcript with Risdiplam. We'll hear about that in a close future. And then arrive, I can call the Zolgensma, since it's approved now in Canada. And there are other SMA modifier that may be a combination of the therapy will be to consider in the near future. The main goal is to prevent the damage and of course to treat as early as possible. So what about the gene therapy? So the gene therapy, you need a vehicle. So the associated adenovirus were identified as probably the safest and the main vehicle to consider for gene therapy, because they are non-pathogenic, they are non-replicating, and very less immunogenic compared to other viruses. Tropism is pretty interesting for neurons, particularly AAV9, and they can be easily engineered. So for Zolgensma, what we're doing, we're packing the SMN1 gene, we're giving a promoter because we want the gene to go on the right cell, and we want the virus to fuse with the neurons and the nucleus. Now we'll show you what's happening. With one single intravenous infusion, you will load the system with the virus, and then the virus will be absorbed by an endosome system, and the capsid of the virus will open, and the DNA will fuse inside in independent episome, so this ring of DNA. And this ring of DNA will be able to transcript because we give a promoter to induce the transcription. What I mean that you can transcript the RNA, and then the RNA will be transferred in the protein. Then we produce the SMN protein. What's happening with the gene therapy in terms of safety? So I have the experience with 3 patients, and worldwide, I think we are close more than more than hundreds of patients. Most common side effects are elevated liver enzyme, fever, and vomiting. So to treat the liver enzyme elevation, this is kind of immune reaction. So you need to treat a patient with steroids, 1 milligram per k. Some people try up to 20 milligram per kilogram. My personal experience I had with one patient to increase to 3 milligram per kilogram. Patient could present with transient thrombocytopenia, but within the week, everything will be back to normal. There is a risk of bruising, bleeding. One case of my patient, they have some bruising, but nothing serious. It's mentioned that some patients they had increased risk of upper respiratory tract. So we don't know if it's really related to the gene therapy or to steroids. What about the indication? So indication with the FDA, there was for patients under the age of 2. In Europe, they were a little bit more precise. They said it's before the age of 2, patient less than 21 kilograms and less than 3 copies of SMA2. In Japan, they were pretty broad under the age of 2. What kind of follow-up and pre-evaluation we need for gene therapy? We need to assess liver enzyme because patients with SMA type 1 sometimes they could have a little bit slight elevated liver enzymes even before treatment. You need to assess the platelet counts and troponin I because troponin I, this is a cardiac enzyme. In the animal study, there were some reaction with the hearts, but nothing serious happened with patients so far. Before giving the treatment, you need to assess the AAV9 auto antibodies because we want to be sure that the patient was never exposed to the virus, because if he has antibodies, you cannot give the medication, of course, because the virus will not have the time to integrate the system before being distributed. 1 day before infusion, you start the steroids. This is the regular dose recommended by the company. It's also recommended to place 2 IV lines, as this is a safety precaution in the sense that if you bust one IV, you want to transfer immediately the infusion in the other IV. You need to monitor the patient for 48 hours. I have to be honest, in Quebec City, we give the medication as an outpatient in the medical day assessment. And after 8 hours, we send the patient back home with a recommendation and a follow-up the day later. If the patient was developing any side effects, will be bring back to the hospital, or if during the infusion there were some kind of side effect, the patient will be hospitalized for monitoring. In terms of monitoring, short-term monitoring, you need to give steroids for at least 30 days, and then if the liver enzymes are back to under 4 times the upper limit, you can try to wean off the medication slowly. You need to taper down over 20 days. You need to check liver enzyme regularly, weekly, at least for the first month, and then can increase every 2 weeks for 3 months. Check the platelets, troponin I with the same frequency. We are giving some specific precaution for the caregiver. The first is related to hand hygiene. This is the level 1 biohazard precaution. So that means the risk of infection with the virus is pretty low, but you need to have proper hand hygiene. You need to seal the diapers and to dispose them in the trash bag, but still before you need to clean the skin, and you need to regularly to assist the kid to be sure he's not developing some liver dysfunction, and particularly if it's developing some yellowish in the sclera of the skin. You need to be sure the patient is not missing any steroid dose. You could increase the steroid dose if the patient is vomiting regularly to be sure he's not developing any adrenal insufficiency and the other complication. I want to talk a little bit about the studies that will put you in perspective why I'm talking about newborn screening and why I'm so excited by that medication. The first study was a start study. The main age patient in the start study, they are close to 5 years now. Patient, they were before the age of 6 months. The things really important to know that with the study, we see the improvement of the patient. This is the CHOP INTEND. It's another milestone scale. You can see that the patient, all the patients, they were above the range of 40, except one patient for unclear reason, and 11 to 12 patients, they were above 40. So the score of 40, this is the score that patients without treatment with SMA type 1, they are not able to reach that. So the natural story showed us that they are all under 40 and they will decrease. To the contrary, you see patients, there is a plateau effect at some point. Even they're close to normal, they're close to 64, which was incredible. Another aspect interesting to know, there are patients now with the combined medications. So out of 10 patients, 4 are nusinersen. So is it because they see not much improvement at some point? Is it because they were decreasing a little bit? This is things that are under evaluation. The silent findings of START study, 59% they were independent sitting. So this is really significant improvement comparing to natural history. 90%, 91% surviving without permanent ventilation. This is really a significant change. And there was another study, part of the study was STRIVE. So STRIVE, the ability of maintain weight, feeding without support, so not having significant bulbar dysfunction, or tolerate thin liquid. So that's all. Another aspect that was not assessed with nusinersen before, and now we know that patients on nusinersen, despite treating the patient very early on, they could develop bulbar dysfunction. So 9 patients, they were able to fulfill the 3 criteria, they were able to thrive. Still, 63%, they maintain weight, which is the main problem with patients with type 1 SMA. Close to 86%, they were feeding without support, so without non-oral support like gastrostomy or permanent nasogastric tube. And to tolerate thin liquid, 54%, which is still pretty good. And then there was the SPRINT study. So there are the study for the patient before being symptomatic, and that was even more dramatic, the response with the medication. We can see that patient with only 2 SMA2 copies around the age between 5 and 10 months, there are a couple of patients, they were able to reach the milestones, I mean, sitting independently according to the appropriate age, which is incredible. The same thing, at some point, there were 4 patients that were able to walk independently at the appropriate age before the age of 18 months. This is another view to see that the patient, in terms of motor milestone, they will reach a plateau. They will close to be normal with only 2 SMA2 copies. I want to remind you, this is the patient that was supposed to be type 1 or eventually type 2, but severe type 2 SMA. What's happening with 3 SMA2 copies? That's even better. Same thing, they could stand independently at an appropriate age in terms of developmental milestones. And 3 patients, they can walk independently. You can see the other patient, they're still in a range of the developmental milestones. So we are still waiting for other data to see if all the patients involved, they were able to walk independently. So this is something improved compared to the previous presentation I gave a couple of weeks before. So there is a European consensus about gene therapy for Zolgensma, and I want to share you a couple of statements. One of the main and very interesting statements. The first statement four is really important. I think it's really important to explain the hope to the parents, because and this is my personal experience, some parents, they were very disappointed because some parent thinks the gene therapy is a cure, which is not the case. If the patient is already affected, even receiving the medication, they could be left with significant disabilities. So that's really important to discuss that with the parents. Second, and this is the main area of controversy, is combination of the medication. So after receiving Zolgensma for patient already affected, should we continue nusinersen or not? This is the main area of controversy. And my personal feeling is under the age of 2, considering combination for patients severely affected is pretty wise, because we know that Zolgensma is not able to transduce all the motor neurons. We know that the first 2 years, SMA protein is really important for the development of the neural motors. So the rationale of combining medication for severe patients is something that would be assessed. There is a study called RESPOND, patient not completely responding to Zolgensma, receiving nusinersen after that. So we will see. But we still need to treat patients in between. And consensus third is really the really push for the newborn screening, and even 14 days will make a big change in the prognosis of the patients. So you have to understand the accessibility of the genetic testing. It has to be fast. You need to receive genetic testing within a week. That's mandatory, I would say, if you want to consider the treatment. And why? Because this is really recent. So I give you a previous. So Zolgensma had been approved by Health Canada recently, the past month, and they were pretty broad. Health Canada, they said this is for pediatric 5q SMA that have fewer than 3 SMN2 copies, or with infantile onset disease. Pretty broad. But yesterday, INES, so the scientific organization from Quebec, gave their recommendation yesterday, and they recommend to give Zolgensma under the age of 6 months for patients with less than 3 SMN2 copies, without depending of gavage and without permanent ventilation. So you have to understand that now this is very tricky, because we don't have any newborn screening in Quebec City, and for me, and Quebec at large. And it's almost unethical to label a treatment like that and to tell me I have to give this medication before the age of 6 months, because on average, you can diagnose patient with SMA type 1 around 3 months, and then you will have to do genetic testing. Usually we have to wait 14 days. So you will start to treat the patient close to 4, even 5 months. So now this is unethical. So we need to step forward and to develop newborn screening as soon as possible and follow the example of the Ontario program. What about the implication of gene therapy? I think this is also something very important to understand and to consider. We're changing the phenotype of the patient. So new treatment will bring new responsibilities and unique dilemmas in terms of the cost, in terms of the disabilities of the patient. So we don't know if we will cure patient. We know that if we're treating very early on, we make a significant change. We don't know for how long the gene therapy will work. Potentially 15 years, but we know at some point we will need to start other treatments. A single therapy solution might not be sufficient. Maybe combination therapy will be to be considered for severe patient very early on. And what about the role of prenatal SMN protein? What's happening? Because even as a fetus, the disease is evolving. So maybe even if we were starting pre-symptomatic, this is too late. Are there any other option? New patterns of motor development may emerge. So as an example, I have a patient, he was typically type 1 SMA. I started to treat him at 6 weeks of age. And despite treated with nusinersen, the motor milestone improved a lot, but it developed severe bulbar symptoms. It's dependent on gavage. Fortunately, he received Zolgensma. So I was able to give Zolgensma when he was close to 1 year old. But still, the patient developed scoliosis. He needed CPAP support despite nusinersen, and he will be left with disabilities. So this is the kind of patient I will consider to combine medication before the age of 2, because we want to push to help him to improve as much as possible in terms of quality of life, and despite the cost. We don't know also what will happen in terms of the gene therapy for the inocuity in a long-term basis with the liver, with the heart, with other organs. So this is something we need to check on a regular basis. And there is a database where most of the patients that receive Zolgensma can be included. It's really important to remember that SMA, it's a teamwork. It's respiratory care, rehabilitation care, palliative care is really important. Nutritional support is really important. This is angular in the care of the patients. Psychological assessment is really important for the parents, but also with the kids. Orthopedic issues arise regularly, scoliosis. It's really important to assess regularly to avoid any other disability. In conclusion, 5Q SMA is based on detection of SMN1 deletion or mutation plus SMN2 copy number variant to assess the prognosis. Early pre-symptomatic treatments can dramatically change the course of the SMA patients. Newborn screening is crucial, I would say mandatory now. It's non-ethical that we have access to treatment without newborn screening in Canada. And early treatment will definitely change the prognosis of these patients. Gene therapy for SMA developed using AAV9 is pretty safe so far. The inocuity is pretty good. Has been approved now in Canada recently. Clinical trials are still ongoing, and we will accumulate more and more data. Implication of treatment will be more fully understood over time, and the area of uncertainty, like combination of the treatments, we will have an answer probably in the near future. Do you have any question? Why you have any question? I want to share you one of my patients, so personal experience. I think it's really good to show you that. This is a patient. She was 1 year, and as you can see, the parents are working with her because she's not moving the leg. She can sit with supports, but it's pretty difficult. She's not moving the leg at all. And the pediatrician was really good because she was referred by the family physician. Then the pediatrician called me and told me, I think you have an SMA patient. So she was tested positive. She has a 3 SMN2 copy. And I did the EMG. The EMG was positive, and we started the nusinersen. She received 4 doses of nusinersen. she was lucky to get the Zolgensma, and she received the first dose of the Zolgensma at 18 months. This is 3 weeks after treatment of Zolgensma, and then she can move bottom feet, and she moved the leg. And then 4 weeks after treatment of Zolgensma, she lift up the legs against gravity. She tried to pull the pants on, which is major. And now she's trying to sit. This patient, I'm not combining therapy. But as you understand, with the label given by Ines, she would not have been a candidate for receiving the Zolgensma because I diagnosed her when she was a year. So this is something we have to consider in the near future. So I really advocate for newborn screening as soon as possible.
Thank you so much, Dr. Christian. Actually, this for me has reinforced why MDC entered into a partnership to start nationwide newborn screening in Canada. You've emphasized that and provided the background as to why that's so important and why we need it in provinces like Quebec, but from coast to coast to coast. So that's been excellent and well said today. There were a couple of questions that if I can read them out loud to you. One individual said, excellent talk. Can you repeat what you said about emerging phenotypes, specifically in the pre-symptomatic patient that you treated with Spinraza, with nusinersen?
Yeah, so that's a really good question. It's in a sense, a good example is really the patient I was talking about. It was a typical SMA type 1. So now he's alive, okay? So he's alive. I definitely changed the natural history of the disease, but he's still left with significant disabilities. So he's 1 year old. He has a scoliosis. He's CPAP dependent. He has bulbar dysfunction, despite nusinersen started at 6 weeks of age. So according to nurture and NGA, should have been better, but that was not the case. So this is one of the emerging phenotypes. So that means that we are able to save the babies, that they are left with significant disabilities. And in a sense, I think this is not acceptable because, as mentioned, one of the mother of that patient, she told me, sometimes I regret my decision. I know he's alive, but I fear for his future because he will left with so much severe damage that sometimes she has this fear. And this is why the consensus of the European group was really good. The statement 4, it's really important to discuss that with the parent before starting the medication, that even with the medication, with the gene therapy, with nusinersen, the patient, they could be left with significant disability. That's really important.
Very good. You mentioned, so Health Canada has approved Zolgensma, and that was a late December announcement. And as part of that, what came up is questions around age, because that wasn't indicated, unlike what we heard from Ines yesterday, which was a specific age group. And the questions that I'm seeing, a common trend is around that. So I'm going to read you the 2 questions. One, are there studies of patients not needing treatment after age 2, around the age 2 to 4, since SMN protein production significantly declines around that age? So would they need it? And another question is, I have a patient, she's type 3 copies of SMN2. She's 3 years of age and has started Spinraza, nusinersen since 4 months ago. Would they be a candidate for gene therapy?
That's a really good question. About the question, there are 2 parts. So the first comment is really good. Exactly after the age of 2, we know that the SMN protein is not so important, probably in terms of motor developmental milestones. So treating early on will be better. And I have the same fear that treating with Zolgensma after the age of 2, I'm not sure we see a significant difference comparing to nusinersen. The main difference will be probably the patient will be stable, will have a plateau after the age of 2. And the only difference is the fact that we'll give just 1 infusion compared to regular lumbar puncture for life. So that's something to consider in terms of quality of life. Secondly, the weight is really important. That's my experience and my main fear, and that was the fear of the patient from Europe, and also this is a same fear shared by most of my colleagues specialized in neuromuscular disorders. The weight, because you are giving a viral load, and the immune reaction is worse with the liver enzymes if the baby will weigh over 21 kilogram. So it could be even dangerous at some point. So that patient particularly, her weight was 12 kilograms and she had the worst liver enzyme reaction. She had a significant transaminitis. I had to increase the steroids up to 3 milligram per kilogram per day. And she developed the low platelet. She had some bruising, but she did not develop any other significant side effect. But I need to treat her on steroids for at least 3 months until I was able to wean off the medication. So that's the main concern. So I don't think for patient type 3 SMA, clinical type 3, they will have access with the Zolgensma after the age of 2. And I think in the other province, probably the CADIT, I'm expecting that the CADIT will give the same recommendation as INES. They will stick with the inclusion criteria, so they will probably recommend under the age of 6 months and under the weight of 13.1 kilogram. This is what I'm expecting, like INES.
Thank you. Once patients' liver enzyme levels stabilize, what is the likelihood they will elevate in the future?
It's pretty low. So far, we have the experience of the cohort treated with the Zolgensma and across the world, and sometimes the liver enzyme could re-emerge a little bit despite weaning off the steroids, but always less than 4 times the upper limit. So it's pretty rare that you need to restart the steroids. So, and in a long-term basis, after 3 months with the liver enzymes close to normal, it's not necessary to continue to check to monitor the liver enzymes. That's pretty safe in long-term basis.
Very good. There's a question here. I know you've shared your opinion on the INES criteria for reimbursement, but rather the question is more so around that G-tube indication or that mention around G-tubes. Knowing that there are many children that are supplementally fed by tube, this excludes a lot of children. What are your thoughts on this?
Yeah, it's pretty tough. It's pretty tough. I think INES, they decided to be very safe because of the cost of the medication. So they decided to stick really with the inclusion criteria. And the thing is, in terms of the bulbar function, we don't know if someone having already bulbar dysfunction will improve with Zolgensma, to be honest. We don't know. We know that despite Zolgensma, patient will develop bulbar dysfunction, but we don't know in terms of improvement if you have already bulbar dysfunction. So this is why I create some controversy of combining treatment in patients because I want to improve them. I want to help them, and even if there are no evidence so far, this is difficult to stay and just watch and not doing anything. If I have access to other treatment, I will consider to try. And I am a scientific, so of course I'm checking and monitoring the results to know if there is something that will support combining treatment in the near future. But so far, I don't know. But I agree with you. This is pretty restrictive for Zolgensma because if you have bulbar dysfunction, this is the end. You will not have access to Zolgensma, and that reinforce again the need of newborn screening because bulbar dysfunction could develop pretty fast in type 1 SMA patients.
Excellent. Just in the final last minute, I know you just spoke about combination treatment. There is a question around what is a current state or current clinical opinion on nusinersen as maintenance following Zolgensma?
It's not recommended. That's the consensus. The European consensus, that's the consensus of most of my colleagues in neuromuscular field. So I have to be transparent and honest. It's mentioned that, and Ines also mentioned that it would be better to wait for clinical trial. So that's the area of controversy. And my rationale is we are treating patients with already some disability. We are giving more close to for 2 million treatment of a patient, and I would say that there would be almost unethical not to try. That's the other side. Not to try, not creating evidence. This is also part of being a scientific. So sometimes, n equal 1 could make a big difference. But I know I'm the black horse of the neuromuscular field currently with this approach.
Absolutely. Thank you once again for your time, for a thorough presentation. If I wasn't able to attend to your question in the chat box, feel free to email us at research@muscle.ca, and I'll be able to share those with Dr. Christian. Thank you all so much for taking the time today. Have a great rest of your day and take care.
Thank you very much. Have a good day.